But I think we've got a quorum with the 4 of us that I count here that we can at least get started. All right, well, I'm happy to get rolling if you want to pull up our intro slides, Sarah.
Yeah, can do.
All right, well, welcome everybody. This is my first meeting as chair of the board today. And I guess we'll read our official stuff to get started. This is meetings being held virtually, hosted by the Utah Department of Health and Human Services and the Center for Medical Cannabis in Salt Lake. Public notice of this meeting was provided as required under the Utah Open Meeting Code and posted on the Utah Public Notice website. The purpose of this board and our meetings is to review the available research, literature, and assist DHHS and Center for Medical Cannabis in their efforts to provide useful treatment recommendations to qualified medical providers regarding the use of cannabis and cannabinoid products for treatment of certain medical conditions identified as qualifying medical conditions. This meeting is being recorded in compliance with Utah's open meetings law. Recording this meeting will be posted to the Utah Public Notice website within 3 business days. Written minutes will also be prepared, and approved minutes will be posted to the Utah Public Notice website within 3 business days after board approval. Here are our board members. I think we have a little tiny update to do to our board members and other staff there to add some new people on.
Yeah, sorry. I did update this, but I think I just chose the updated
So
version.
the
So
old
sorry about
version
that.
or something. Yeah.
Yeah.
I'm not offended. Matt can take over if he wants. He can do another year. That'll be fine. Yeah. And once we get to our public comment period at the end of our meeting time, we'll allow 2 minutes for each individual to make their comment, and everyone should raise their hand. I would like people to state their names, any affiliations that they have, and disclosures to make, and then make any comments, and then we'll reserve board comment after we hear all of the public comments that are going to be offered. Yeah, there we go. Okay. All right, I think that takes care of our official intro stuff. Do you have minutes from June there that we can take a look at, and we can quickly review these, or if anyone has any discussion points or updates to the minutes before we ask for a motion to approve these? I would take a motion to approve the minutes unless anyone has any discussion points or things to add.
I'll make a motion to approve the minutes.
Thank you, Matt. Second.
Second.
All right, so we have a motion to approve. Any discussion on that? Then I guess we will take a vote to approve those minutes if we want to do so by a show of hands there. All in favor? And anybody opposed? Okay, it looks like we are all set and have a unanimous vote to approve our minutes from June 2024. Thank you, guys. Next, we'll be revisiting our safety document. So thanks to everyone who put in some comments and work on this. I had a lot of great comments from everybody on what to do with this. I worked on it, Matt worked on it, some anonymous folks. I don't know exactly who everybody's comment was on there, but we took all those into account. Everyone did want to add lots of things, and we tried to get this to fit still within our 1-page thing, recognizing we could write an entire handout on each one of these bullet points on what to do, and keeping this as a really high-level piece. I had our health educators here at the Poison Center help me with, simple, plain language, and remove some of the more medical sort of jargon that was in there as well. So this is the same points. I believe we added some things about the substance use disorder, added a link to the drug interaction tool, and otherwise, I did not end up including some of the more detail that other folks offered, but we can provide links to those resources, especially with regards to things like what is the long list of drug interactions, right? We can't even begin to include things there except for to ask people to look out for them. So I think we got all of this on one page here. Boom. And then we have a certain list. I think these are all of the references that people provided to me of certain studies. I included some of the things that I've used to refer people to from CDC, which is good general information on cannabis health effects and adolescence, and then some of the specific trials or reviews that some of you linked to down at the bottom. So I'm open to including any other additional resources there, recognizing that could also be, fairly exhaustive and wanting to pick some of the high points of what we point people to. Does anyone have any comments or any further things to add or change to this after our initial round of revisions?
Mike, I'll just say, this is Taylor. I think it looks great. It's really like, much better than like the earlier draft that I saw. And I think it's very clear, easy to read, covers a lot and a little bit of space. I was thinking about the reference page, the second page, because I think one of the things we talked about last time was that this is sort of two-tiered. There's like kind of a, this is the quick kind of Cliff's Notes version on page 1, but if people want to go kind of take a deeper dive or look into things, they can use the reference page. And so I guess the two things I thought, one, I think we could include more references. There are some like the National Academy's like summary report from 2017 would be a good one. And like there's lots of other things we could include, but kind of related to that, I wondered if we wanted to list the literature by topic that's, maybe loosely correlates with page 1. So
that's a good point because right here it's just kind of scattershot of here's I have put all the things there. I like that. I don't know if we have to have something for every single one, but it can at least be in that same order about things. And I think, certainly the National Academy report is good. It's something the board has used extensively in the past. And I guess I would like any resources or references anyone wants to point me to, then please send them my way or just go ahead and add them to that document so we can include them there. And I can easily just copy paste those same 1 through 10 topics, and then we can slot things in wherever they belong there.
I think that's a great idea as well.
Anyone else with comments or changes here?
I think it looks great, Mike.
Yeah,
Cool.
I agree.
Thank you. My thought was that we could approve this today if we are going to add a section with a bunch more references. We should probably all like finally sign off on it. At this point, we aren't planning another meeting till October. And then if we approve it in October, with this thing doesn't make it live until 2025. I don't know what the best path forward is so we can get this moving, or something that we can do offline after, tentatively approving what we have here, and then just like cleaning up some references, if that would be acceptable, or if we want to bring this back to the board for a full review and vote in October.
I'd be comfortable making a motion to approve it today.
I'll second that.
Okay. Any further discussion on that before we take a vote about approving today and then doing a little tweaking afterwards offline?
Yeah, I guess we could say that the motion is that we approve it even with some of the additional references pending, I don't think I would object to anything that we add on the reference page.
Okay. Well, we'll keep what we have here. We're not changing the meat of what's going on, but we're going to provide additional references for people by topic on the second page, with this main section still being basically the same. Okay. Well, with that, then I would ask for a vote of everyone in favor of approving the main portion of the document. The raise of a hand. Okay, anybody opposed? I think we got us all already there in favor. Okay, all right, motion passes. What I will do is, I would ask everyone who, if you have a pet favorite reference that you would like me to include, let me know. Otherwise, I will go and grab a couple that I'm aware of for each of those topics. I already have some of those right that I included there, and we'll just slot them into the appropriate place. I think I copied and pasted all the ones from the comments. So if you see that I missed yours or somehow forgot it, then please feel free to add it in there. And then I probably won't get that done this week because I'm heading out of town, but we'll get it worked on by next week to have it fully finished. Okay, great. Thanks, Taylor. I guess one other piece that I was going to ask, whether this is official to Rich or someone else, we would like at the Poison Center to kind of host and distribute this. This is kind of part of our core thing of, safety and helping people understand medication safety things, especially. And we would love to be able to distribute this and even include our logo on it, if that's something that's acceptable. I know we have some other information from Center for Medical Cannabis that has Poison Center information and logo on it. And so we would love to do something like that as well with this document, if that's okay.
Yeah, what we can do is after we make those additional tweaks, we can share it with our public information office and let them know. And who should we have them reach out to, Mike? Should we just have them reach out to you, or is there someone else at the Poison
Probably
Center?
reach out to me. I don't know if you
Okay.
know Sherry Pace. She's our outreach educator, PIO.
Yeah.
But anything that gets approved with our name on it then comes to me as well. So if you just want to send to me, then I'll get it to our two people who would be mainly in charge of that end of things. So we can just keep it simple and go through me.
Great. Yeah, I think that's a great idea. We can work on that.
Okay, cool. Well, thanks, guys. I think this will be a great document. I'm glad we got these two things here with the, how to talk to a patient about cannabis, and now these safety things. So I don't know what else we'll have to do in the future, but if anyone has ideas for other sorts of one-pager documents to have to go along with our more exhaustive evidence review, those would be interesting. I don't have anything off the top of my head, but I think that would kind of take care of these two big things that we've been working on over the last 6 months or to a year. I guess we can move on to the persistent debilitating muscle spasms. So I should have that in that first draft document there, Sarah. I did not get as far into this as I meant to, but I think I have the main pieces suggested here. So this is the trouble. This is a new document. We had previously kept this with MS, and so I realized I had bit off more than I could chew for attempting to do all this in one afternoon yesterday to get it all in there. And we had the MS information there as an example. And I think the first place to start would be kind of in that yellow box, Sarah, because the big line things are these three statements here, which are basically all props and credit to Lauren from her research review with a tiny bit of rephrasing of our previous statement around muscle spasms was a single one that was insufficient evidence for adults with spinal cord injury. And that was part of the MS document previously. And so this separates out multiple sclerosis and from the persistent and debilitating muscle spasms. I included this single statement there, may result from a variety of distinct clinical conditions in adult and pediatric patients. To say, why are we making 3 statements when this is a single qualifying medical condition? Because I think it does bear having more than a single statement just for spasms, because it's such a non-specific word. As I have it phrased here, it's sort of grouped by either level of evidence or the patients it applies to. So the first one is spasticity in adults, spinal cord injury, insufficient for spasticity after stroke, and insufficient for children. And those are children that have been studied with TBI or cerebral palsy. I'm happy to take comments on any of those levels of statements before we go down and look at the rest of the document. It should be basically the same sorts of things that Lauren had in her final conclusions in her document. We could pull any of that up, or her presentation, or anything else. Or Lauren, if I have misrepresented some of your conclusions, or anyone wants to comment, let me know.
I think as always, Lauren's done an amazing job. I didn't have any major issues with the document.
And as a
think-
reminder, what this changes is previously we had said basically insufficient evidence for any of this. And here we're kind of promoting one of these up to weak evidence or limited evidence is what we're doing. It's taking it, because previously we're saying not enough evidence to say anything about anything for spasticity. And so we're making at least some light recommendation now.
Yeah, I mean, with the changes that are made though, the most we could say is weak evidence. I mean, because there's just not a lot out there.
Yeah, I was really struck by the heterogeneity again of different products at different doses for different times and different patient populations, and
Yes.
really struggling to have anything truly coherent that speaks to this whole piece. And considering this is just the umbrella condition of debilitating muscle spasms, is very, very broad. As Lauren was well aware of doing the literature review, and I was reminded going through this of it is really tough, because you end up with like basically a single trial almost, for some of these things, with all of the risk of bias that comes with each of those. So I think this is about as strong as we can really say for any of these conditions.
Yeah, I agree. And I think the document is great. And I think the main benefit is just like you pointed out, even though it seems anticlimactic because it's all kind of weak or insufficient, but the point of this is to start separating out these conditions. Because as you said, muscle spasticity and muscle spasm is a broad term that people use in different ways. And I think it's useful to start separating out and say, well, we have done research on this and this and this, and it helps with MS, but it doesn't help with these others. And I think that the document stands to start making those distinctions, and I think that has value.
One thing I didn't include here that was in some of the prior ones was the form of cannabis. Sometimes in these statements we had included oral cannabinoids, nabiximols, or whatever else. And here there was a lot of different things used in the various studies, so I did not include. I think most of them were, some were like oral cannabinoids, some were CBD rich, some were nabiximols, and there were so many different ones. I didn't want to just include a full list of all of these things that have weak or insufficient evidence. I think all that I do have included later on. I just don't have them in these summary statements, which had been present in some of the others where it was a little bit more defined, but I decided to leave out the form of cannabis from these summary statements.
And I have to admit that my comments at our last meeting were somewhat biased, because in the epilepsy community, there's more work focusing on infantile spasms, and Lauren did a great job of reviewing the literature, and she sent out an email back in May to the committee, and she found 8 articles. I think there's actually a few more than that that aren't review articles, that are more case study that have come out recently that kind of summarize things as well. But I don't think that should be included in this document. That might be something to consider in the future as a separate entity, since it's very specific to Lennox-Gastaut syndrome and some of the genetic forms of epilepsy or chronic spasms or spasms epilepticus. So I think it should kind of either be an addendum to the epilepsy statement or be a standalone even.
Yeah. And I don't know if all of those cases would be going through the compassionate use board with a case for at least medical cannabis outside of Epidiolex.
Sure.
But I suppose some of our statements could help to inform the compassionate use board, though I haven't been too familiar with that board and exactly their process and things.
But I would refer folks back to that May email from Lauren, because that was, she talks about the 8 articles that she found.
Well, I think I agree with that. I'd be more than happy to entertain a new document to talk about some of the pediatric epilepsy syndromes or infantile spasms, which I think certainly represent a very different entity from adult spinal cord injury or stroke for sure.
Yeah.
That might be a good idea to have its own treatment or its own document.
I guess my question would be is if we're supposed to be talking about qualifying medical conditions, would any of those fit under persistent and debilitating muscle spasms for us to make a separate document if it's not about something that is a qualifying medical condition? If that made sense, right? If like we're talking about infantile spasms, can we say that fits under persistent debilitating spasms, but we consider this pediatric subset to be so distinct that we're just going to address it separately, but we'll say it would qualify under here, yet it doesn't qualify because they're pediatric patients and would have to go through the compassionate use board.
Yeah.
I guess it's like, is this within our scope to say something like that?
I think it definitely is, because it's all under the program and related to treatment just specific to pediatric patients.
Okay.
And if there's enough data to separate it out and make a recommendation, then yeah.
Okay. That sounds good. That sounds good to me. Misty, are you volunteering to draft something up on that end?
Well, the thing that, and I said this last time, the thing that might be problematic is everything's very heavily skewed towards Epidiolex. So majority of the literature out there is going to be focusing on it rather than medical cannabis. So if you want me to put something together on medical cannabis, it might be very, very short. If you want to include cannabidiol, there's more information out there about that. So that's why I hesitated last time to really push for it, because I think it's going to be very heavily weighted towards Epidiolex, which is already approved for that indication.
Yeah.
So I don't
well, if that's the case, then people should know that that's the thing that is known to work and not necessarily anything that's THC predominant or whatever else it would be, or 1-to-1. Or Taylor, do you have any comments on this?
Yeah, I have one question and then 2 comments. So first was who the primary audience of these documents will be. If it's patients, if it's providers, if it's both. That was one question. And then the other, I guess the comments were, I do think that I know it gets a little bit dense sometimes to include information about the type of cannabis product, but this Epidiolex illustrates this really well. I think in like a call out box or in a summary table or something, we probably should have a distinction between like THC dominant products, CBD dominant products, and then like other, which would, include a lot of things. And there it gets really complicated beyond that. But I do think we know some things about what CBD, like how it works and what it may be effective for, and we know some things about THC and how it works and what it may be effective for, and the side effects are very different and the risks are very different for those. And I think most people, and even some providers, don't always get that, like that. But it's almost like they're different drugs. They are different drugs, right? So having something, I mean, I wouldn't get overly complicated, but at least to maybe divide it into like those three categories. You know, we've got CBD, THC, other, and evidence for like, you know, what's effective there. So if you were talking about infantile spasms, we could say Epidiolex, FDA approved, THC, you know, unknown, not approved, or something like that.
Yeah, I think that would be very reasonable for that document to break it out like that, where we can make, you know, good evidence, strong evidence, whatever the level of evidence for that is, and then make a separate statement about the different cannabinoids where there's such distinct results based on the product. I think that would be a great idea. I don't know if that applies. Are you talking about this document today, or if we're doing more on that infantile subset?
Well, either one. I mean, I think if we were to go through all of the you know, qualifying medical conditions for the state, which that list will probably change over time, and I don't know exactly who or how that happens, but we'll have to kind of keep up with that. But for any one of those documents to kind of say, this is on the list, and like we would say, you know, the primary effect, if we know it, is driven by THC or CBD or both. And you know, something along those lines. So I think just like if even if we had like a call out box for each qualifying medical condition, like this yellow one,
Yeah.
and there was just like a section that said like, maybe you had like check boxes and said THC, CBD, other, and like you check 1, 2,
And for
3
which one is in there?
of those.
I like that
just-
idea.
Just to make it simple to say like, this is what we're talking about with this indication.
Yeah. There's a lot of those details are further down in this document, but I think it would be good for some top line, you know, pieces. Like here I have it broken down by each piece and which things were done. There was CBD rich oil and nabiximols. It was up there just a little bit more, Sarah. So I think we could move some of that to the top.
Almost just even like a checkbox to say like,
yeah.
this is relevant here.
Like, can I simplify these products down to a checkbox thing of THC, CBD predominant, nabiximol, or otherwise? We'll see what we can come
A
up
lot
with.
of like asterisks and footnotes maybe, but
Yeah. We do have some of those statements, like I said, included in the other documents, and here it was a little bit all over the place. But if that's the case, then I think people should probably know from the get-go that it's a little bit all over the place. And I see these documents as very much for providers and not necessarily meant for the general public, because this is and there's a lot of cleaning up to do with the rest of this. I guess we could go now to just under the yellow box, Sarah.
Actually, Dr. Moss, I had a couple things I wanted to mention about
Yes,
this.
please.
One is just a question to pose for consistency across documents. I noticed that you changed the limited rating to weak evidence, which totally makes sense and is fine. But we've been using the National Academy of Sciences ratings and the other documents that always uses limited for that category. So I just wondered if consistency matters.
Do you have those criteria? I thought I was using some of their language. Yeah. So that's like under limited evidence, for instance, I used under limited evidence, there is weak evidence. But if we've said there is limited evidence in the other ones, then I guess we stay consistent with that same thing, and instead of making people think we have a distinction between weak and limited.
Yeah, that's a good catch, Lauren.
Yeah.
And
that's where I pulled that from, but I think limited sounds great.
The other comment I had was just all of these graded statements are for the outcome of spasticity. In the presentation, I had also briefly addressed the outcome of spasms.
Yeah.
And so you may have purposefully left that off, but I just wanted to bring it up in case you know, you wanted to consider that or not.
No, that's a great point, and I felt like I don't know what to do with saying this is spasticity, but this is spasms, and how is anyone supposed to interpret that or know what that means when, well, this will help your spasms, but not your spasticity. And then the patient says, what? What do you mean? So if you have suggestions, or Matt or someone else, of like how do you separate those two ideas out from this literature versus the outcomes versus the disease entity in a way that is helpful for a provider who is approaching a patient with this? I would love to hear some thoughts.
I'll just comment that the outcomes that were measured that I'm referring to is usually something that measured like the frequency of spasms that someone was having in a day. And although some of the cannabinoids helped improve spasticity overall, they, whenever the frequency of spasms was measured, that didn't significantly improve. I don't know if that helps address your question, which is a great question, but that's all I can add.
Well, I agree, Lauren. I think that you made the point earlier that spasms and spasticity and all those terms are used interchangeably or used with different and connotation, and we're not going to be able to change that. So if we just make the distinction and then try to refer back to the disease state, I think that's the one thing that we can rely on is the disease state. And anytime we have if it's confusing, I think if we can defer back to the disease state, that would be helpful. Because you're right, the spasms and spasticity are symptoms, and they're often confused, the terminology. So, which, by the way, I had another comment on Taylor's comment, on the infantile spasms, and he made the comment, we're kind of sticking to the approved qualifying condition list. And he asked, how does that change? Well, it changes with the legislature. We haven't had a lot to say about that recently. They approved acute pain, without our input. But what if we went to the Compassionate Use Board, now that they have 4 years of experience, ask them, what do you want to see? You've been treating pediatric patients. What's your most common thing, and should we make it a disease qualifying condition rather than just, they approve sort of this nebulous, they just get approval case by case. What is their most common one, and should we make it a qualifying condition and then do a review on it?
And I think that's happened in the past. They've had a few that have related to, I think, anxiety and a few others and there was some comorbidity involved, where it wasn't just one condition, but they had a few others. But maybe at the next meeting, in between meetings, we can send out an email that has a list of some of those conditions, Matt, and that way the board is aware, and at the next meeting, you're welcome to put it on the agenda for a discussion. I think one of the things is there's not a lot of, in the past, there hasn't been a significant, I guess, growth in the number of new conditions that there's evidence of. And so they're really, one of the duties of the board is to identify those where there's new evidence, right? But there just hasn't been a lot of new evidence of scientific rigor that has been so significant that it would cause new conditions to be added, right? And I think I don't want to speak for the CUB, but the Compassionate Use Board, I think they've played a key role in identifying unique circumstances on a case-by-case basis where it's justified. At the same time, when there's those that are justified, there's some where it's not, and they've not approved or requested additional evidence, and additional evidence has not been submitted. So yeah,
I guess just periodically we should ask them, should we review what conditions should we review that you're seeing a lot, if they happen to have one.
Yeah. Sarah Dash and I can pass that on for sure.
Sorry, I didn't mean to sidetrack this discussion.
Yeah, so I guess I'll bring that back to Matt, Lauren, the comment here about including muscle spasm frequency. would you like to see that in the yellow box or in the discussion below?
I would probably suggest below outside of the yellow box, just because I think it's going to require 1 or 2 sentences to explain. In the yellow box, really, we need to keep succinct.
Yeah, I'd agree with that.
Okay. No, I like that. Let's go down to this next section. I included right there at the top, you know, these spasms, like this qualifying medical condition is such a broad term. Here's all the things that we're talking about, among other possible things that could also result in spasms. And then my next little paragraph is spasms and spasticity, and having to do my own refresher on what is spasticity and what does a velocity dependent increase in tone mean. Yeah. And then spasm is incredibly nonspecific, from cramps to spasticity or clonus or dystonia or other things that get named. So it's, you know, all over the place there. This next section, I think, gets at some of these comments as far as product form, and some of the outcomes that were there. This, like I said, this is the section where I was really running out of time and starting to feel overwhelmed to distill anything down further from Lauren's review, because there were just so many pieces and different trials that all talked about a slightly different thing of including it all in here. So this is a section of this that I think I could really use comments and help with everyone. This is really just rearranging Lauren's report into these sort of separate entities here. So I think it does include most of the things people have brought up, but I'm completely open to wordsmithing all this, because this was where I did not do a lot of refinement on this section yet. And also ignore the references right now. They're not in order, and we start with like reference 17 and things like that. So that's all out of order at the moment. So it sounds like we may be at the stage where this needs some attention from the individual board members for some edits and some comments over the next few weeks, where we all get a chance to work on this, you know, first draft section before we bring back a finalized version for everyone to sign off on.
I agree, Mike. We probably just need to do this as homework and make sure all the I's are dotted and the T's are crossed.
Okay.
Spell check it and all that.
Yeah. Well, good. I think hope this was enough to get the ball rolling, which
Yeah.
is what I was hoping for, of the big statements and then wordsmithing spasticity versus spasms, including some things on the product types for these various statements, and then cleaning up the language of things below. But it sounds like we're generally in agreement as far as our level of evidence goes for these various pieces.
Sounds great.
Okay. Does anyone else have any other comments on that document before we move on? Okay. Well, homework assignment for everyone to take a look at things here, and please feel free to put in your own edits or comments on this working document. Okay. We're just like so on track today. We're like 2 minutes ahead of schedule for every agenda item. I love it. Lauren, you want to take it away?
Sure. You just, oh,
Do you want to present, Lauren, or would you like me to present?
it might be easier if I present, just otherwise I'll be telling you to switch slides. I think you might just have to enable the sharing. And if that's a problem, then it's fine with me if you share the presentation as well.
It says all participants should be able to, so.
Okay, so rapid change of topic. Today, we're going to be talking about the experimental evidence for the use of cannabis or cannabinoid-based products in people living with HIV or AIDS, abbreviated PLWHA. The purpose of this review is to summarize the clinical evidence for the use of cannabis or the cannabinoid-based products, which I abbreviate CBPs, in people living with HIV or AIDS to assist the CRRB in updating existing guidance. I searched for systematic reviews of experimental controlled trials, or ETs, including randomized or non-randomized clinical trials. And based on the literature search dates of systematic reviews, I also searched for recently published ETs. I included trials of people living with HIV or AIDS that used any CBP for any treatment duration that reported any efficacy or safety outcome. I summarized primary safety and efficacy results from these included trials, and I also extracted risk of bias ratings for the included trials from systematic reviews when available. Overall, I identified 12 experimental controlled trials, 11 of which were randomized controlled trials, abbreviated RCTs. These trials used a variety of study designs, including parallel or crossover treatment groups, and 2 of the crossover trials used staggered treatment periods where they administered 3 different treatments in a staggered order with multiple treatment sequences that varied by participant. Most trials were described as at least double-blinded, whereas 2 trials were open label and 1 trial was partially blinded. Overall, the studies were short-term with a median treatment duration of 25 days and a range from 1 day up to 12 weeks. Most trials were small. The median number of enrolled participants was 34 per trial, and some trials enrolled people living with HIV or AIDS who had specific symptoms, including 4 trials of people with HIV-related neuropathic pain, and 3 trials of people with anorexia and weight loss and/or wasting, which primarily included people living with AIDS, abbreviated PLWA. I refer to the remaining 5 trials as general because they did not target people with specific complications. Some of these trials were safety focused, whereas others measured a variety of outcomes. All trials included adults, and most participants were male. When reported, participants' concurrent use of antiretroviral therapy, abbreviated ART, and the degree of virologic suppression varied. 6 of the 12 included trials were not cited or addressed by the current CRRB guidance for HIV or AIDS, including 4 general trials and 2 trials in people with HIV-related neuropathic pain, abbreviated HRNP. So in the following slides, I will address details about these trials, followed by major efficacy results. The 4 trials of people with HIV or AIDS and symptomatic HRNP were primarily short-term, blinded, crossover RCTs with treatment durations ranging from 1 day to 4 weeks. Most participants were men with chronic pain of at least mild to moderate intensity, and Ellis et al. Required participants to have pain refractory to at least 2 analgesics. The trials by Abrams, Ellis, and Ibach allowed participants to continue other analgesics during the trial, while it's unknown if the unpublished trial allowed that. Most participants were receiving ART therapy and had experience using cannabis. The unpublished trial and trial by Abrams et al. Primarily included participants with current cannabis use. Smoked cannabis 3 or 4 times daily for 5 days significantly reduced patient-reported pain compared to placebo in the trials by Abrams and Ellis. Results from the very small unpublished trial that compared a single vaporized dose of cannabis at 3 different CBD to THC ratios described acute reductions in pain associated with each dose, but firm conclusions from that study are lacking because it was small, it lacked a non-cannabinoid comparator, and did not report statistical comparisons. In contrast with those other studies, 4 weeks of oral cannabidivarin 400 milligrams daily failed to significantly reduce patient-reported pain versus placebo. 3 RCTs from the 1990s with a duration of 5 to 12 weeks targeted people with with HIV-associated anorexia or wasting. Only Beal et al. Required a diagnosis of AIDS, but based on the CD4 positive lymphocyte counts and comorbidities at baseline in the trials by Strew and Timpone, most patients in these trials were living with AIDS. Each trial required that participants had lost weight or had anorexia with a lower than normal body weight. Participants could tolerate oral intake and had not consumed cannabis within 20 to 30 days before the trial. Most participants in the Strew et al. And Timpone et al. Trials were receiving ART, whereas the ART treatment status in the Beal et al. Trial is unknown. Notably, the trial by Beal et al. Is the pivotal trial that led to the FDA approval of dronabinol for AIDS-associated anorexia and weight loss. Dronabinol 2.5 milligrams to 5 milligrams twice daily for 5 to 6 weeks tended to increase appetite compared to placebo based on patient-graded appetite scores or daily caloric intake. However, results were only statistically significant in the larger trial by Beal et al. Dronabinol modestly increased body weight by 1 kilogram at 5 weeks versus placebo and resulted in 22% of patients gaining at least 2 kilograms compared to 10.5% of the placebo group at 6 weeks. However, these differences were not statistically significant. Strew et al. Found that dronabinol treatment was associated with increased body fat mass. In the third open-label 12-week RCT by Timpone, compared dronabinol 2.5 milligrams twice daily to magistral acetate, which is FDA approved for anorexia, cachexia, or significant weight loss in people living with AIDS. Both dronabinol and magistral similarly increased patient-reported hunger from baseline to 1 week by a statistically significant amount, but no significant differences were observed after the first week. Magistral acetate treatment resulted in significantly more weight gain than dronabinol, including weight gain of 6.5 kilograms on average compared to a weight loss of 2 kilograms on average with dronabinol treatment. 3 of the 5 general trials were crossover trials conducted by the same research group. The 2 trials by Haney et al. Used staggered designs with double dummy blinding, whereas Betty et al. Did not address randomization and may have been non-randomized. These were short-term trials ranging from 1 to 16 sequential treatment days. Each trial targeted medically stable people living with HIV who were frequent recent cannabis users and who were taking at least 2 different ART. Frequent cannabis users were targeted because they wanted to explore the tolerability of high-dose dronabinol in that population. Haney et al. 2005 and 2007 each included some participants with low body mass. Regarding the remaining 2 general trials, Abrams et al. 2003 was a 3-week parallel group RCT, which was blinded for the oral regimens, but not the smoked cannabis regimen. Abrams et al. Included people living with HIV or AIDS with no recent weight loss and no need for acute treatments who had experience using cannabis. 58% of participants had undetectable HIV at baseline, and all participants had stable HIV RNA levels for at least 16 weeks. Participants were required to be on a stable ART regimen that included either the protease inhibitor nalfenavir or indinavir. Mubumba et al. 2022 was a small pilot open-label safety-focused 12-week RCT that included participants with HIV with a suppressed viral load who had been on chronic ART for at least 3 years. Although most participants in the Mubumba et al. Trial had used cannabis previously, no cannabis use within 1 month before the trial was allowed. 4 of the general trials reported a body weight or appetite outcome. Haney et al. 2005 divided participants into those with a low body cell mass for height defined as less than 90% of normal and normal body cell mass. Both trials by Haney et al. Found that high-dose dronabinol and smoked cannabis for 1 or 4 days significantly increased mean caloric intake compared to placebo. However, acute caloric intake only increased versus placebo in the low body mass group, not the normal body weight group of the Haney 2005 trial. Betty et al. Found that high-dose oral dronabinol treatment significantly increased caloric intake versus placebo from baseline to day 8, but not from day 9 to 16. Regarding body weight, Abrams et al. Found that smoked cannabis or oral dronabinol 3 times daily for 21 days significantly increased body weight versus placebo. and Haney et al. 2007 also found significantly increased body weight versus placebo after 4 days with the highest studied dronabinol dose in cannabis with the highest percentage of THC only. Dronabinol did not significantly increase weight versus placebo in the trial by Betty et al. So moving on to safety outcomes across the 12 included trials. Overall, treatment with smoked cannabis for 21 days or oral cannabinoids for up to 12 weeks was not associated with significant changes in CD4 positive or CD8 positive T lymphocyte counts among 2 trials of people living with AIDS and 2 trials of people living with HIV or AIDS. 2 trials who performed more detailed immunophenotyping found that the phenotype of some of these cells might change during treatment. One of the investigator groups concluded that the changes would not clinically change the functions of those cells, and the other study reported possible improvements in the proportion of exhausted or senescent immune cells. Overall, short treatment of people living with HIV or AIDS with smoked cannabis for 5 or 21 days, or oral THC with CBD or oral CBD for 12 weeks was not associated with significant changes to the HIV viral load. This was measured among trials of patients who were all virologically suppressed, had a mixed population with 58% of patients having an undetectable viral load, or patients with an unknown virological suppression status at baseline. Notably, the shorter trials by Abrams and Ellis may not have been long enough to detect significant changes. Over 14 days of treatment, smoked cannabis or dronabinol was associated with modest changes in the nalfenavir and indinavir pharmacokinetic parameters of maximum and minimum concentrations and area under the curve versus placebo, but the changes were not considered clinically significant by the study investigators. Of the modest changes, decreases in the indinavir maximal concentration by 14% with cannabis versus with placebo was statistically significant. Although I found interest in using cannabis in the management of HIV-associated neurocognitive disorders, abbreviated HAND, reported in the literature, I found no experimental trials that specifically targeted people with HAND or that acknowledged including people with HAND. 2 short-term trials among people living with HIV or AIDS who were frequent cannabis users found high-dose dronabinol might impair some aspects of cognitive and performance versus placebo. However, cognitive performance results among the 3 trials were inconsistent and may not have been reliable due to confounding factors. In the 2 trials that administered smoked cannabis, its use was not associated with altered cognitive performance versus placebo. 9 of the 12 trials reported details about treatment discontinuations due to adverse events or illness. The 2 short-term trials by Haney et al. Did not report any discontinuations due to adverse events. And across the 7 other trials, the majority of adverse events that led to discontinuation were neuropsychiatric in nature. Mabumba et al. Reported that 2 out of 5 patients who received high-dose CBD 800 milligrams daily experienced hepatotoxicity, including 1 case of life-threatening acute hepatitis that occurred in a patient with pre-existing hepatic disease. Among the 3 trials of people living with AIDS, patients also discontinued treatment due to HIV progression or illness that may be associated with AIDS. Regarding other safety, when reported, most adverse events appeared to be of mild to moderate severity. The most common adverse events associated with cannabis-based treatments were neuropsychiatric in nature. Ellis et al. 2009 described a trend towards a greater frequency of moderate to severe adverse events with smoked cannabis versus placebo. And Timpone et al., who primarily included people living with AIDS, reported a high incidence of any grade 3 or 4 adverse event, although the incidence was lower with dronabinol compared to any magistral treatment group. During the treatment with oral cannabidivarin, 1 patient who had pre-existing atherosclerotic risk factors experienced a myocardial infarction. Smoked cannabis was associated with acute asymptomatic significant increases in heart rate versus placebo that resolved without intervention. And it was also notable that 2 patients with type 2 diabetes in the 12-week Mabumba et al. Trial experienced worsened glycemic control, although it's possible that other factors contributed, including binge drinking in the case of one of the participants who is also the participant that developed the life-threatening acute hepatitis. So I extracted risk of bias ratings using a Cochrane tool from systematic reviews for 8 of the 12 trials. Only the trials by Abrams 2007 and Haney 2005 out of 8 trials lacked any high risk rating on any of the bias domains. However, Haney et al. Was rated as having an unclear risk of bias in all measured domains due to insufficient reporting of their methods. The domains rated as a high risk by at least one trial were related to blinding, incomplete outcome data, bias from randomization or allocation concealment, or other. In the other category, notable sources of bias, according to the SRs, included that participants in the Ellis et al. Trial may have had high positive expectations from cannabis use, and participants in the Haney et al. 2007 trial were allowed to use cannabis at home between the staggered treatment periods. Overall, considering the risk of bias ratings, only the 2 pain-focused trials by Abrams et al. 2007 and Ellis et al. 2009 are moderate quality, and the other 6 trials are considered to have the lowest rating of low quality. There were not bias or quality ratings from an SR for the 3 most recently published trials, including Mabumba et al., Ibach et al., Betty et al., and the unpublished trial. These trials were noted to have potential bias concerns arising from randomization or allocation concealment and blinding. As is expected of any body of evidence, there are limitations to the 12 experimental trials among people living with HIV or AIDS. Most of the trials are low quality with significant bias, with concerns for significant bias resulting from the lack of or unsuccessful blinding, incomplete outcome data, or other bias. Overall, there's a lack of long-term experimental data, which is potentially concerning due to the overlap between potential safety concerns with long-term cannabis use with comorbidities that occur at a higher rate among people living with HIV or AIDS versus the general population. We are aware of one single-arm clinical trial extension of Beal et al. 1995 that established the safety of dronabinol for up to 12 months. Additional safety information could be gleaned from observational studies, which were not included in my review. There was also a lack of experimental information about the impact of cannabis or cannabinoids on mortality or major morbidity in people living with HIV or AIDS. There are also potential generalizability concerns, for example, due to differences in the available ART regimens that were used in the studies versus what's available today, particularly for the trials of people living with AIDS with weight loss that were conducted in the 1990s. The results may not be generalizable to most patients today, since those trials included participants either who were not receiving ART or were likely receiving ART regimens that are less effective than those used today. An expert Canadian 2023 guidance statement focused on chronic pain management made recommendations for use of cannabis-based products in people living with HIV that was informed by 2 RCTs and 1 cross-sectional observational study. They strongly recommended cannabis-based products for muscular or neuropathic pain with an inadequate response or intolerance to other treatments based on moderate quality of evidence. Apparently, based on the observational data and/or their opinions, the experts also strongly recommended cannabis-based products for HIV-related symptoms of nausea, poor appetite, weight loss, anxiety, or depression based on low-quality evidence. The CRRB's guidance for the use of cannabis in people living with HIV or AIDS has not been updated since it was originally published, as far as I'm aware. That document includes 3 formal graded statements as shown on this slide. These statements concluded that there is a limited evidence of the effectiveness of cannabis for painful HIV-associated neuropathy and wasting syndrome. Additionally, another statement about chronic pain in general is included, which is identical to the graded statement in the CRRB's persistent pain guidance. Regarding potential updates to the guidance document, I included some things to consider, but of course, you're welcome to consider other changes or not include these changes. The CRRB may consider including some of these changes. Note that the level of evidence grades that I refer to are from the 2017 National Academies Report for Cannabis. And if you refer to Appendix C of the report, I have the explanation of those categories, and I also have those included in later slides in this presentation. In my opinion, the CRRB may consider maintaining the graded statement of limited evidence for the treatment of HIV-associated peripheral neuropathy with cannabis. If desired, you could consider specifying that the evidence is for chronic pain and in the short term, since the two moderate quality RCTs in support of this statement treated patients for only 5 days. You could also consider adding a graded statement to address the single 4-week crossover RCT that found oral cannabidiol did not reduce patient-reported pain versus placebo. For example, that there's insufficient evidence of cannabidiol's ineffectiveness. The CRRB may also determine whether to keep the graded statement and associated details about treatment of neuropathic pain in general in the HIV and AIDS document. If it's decided to keep this, I suggest updating the supporting text to be consistent with the updated persistent pain guidance document. For the graded statement about HIV wasting syndrome, because nearly all experimental evidence in people with probable wasting studied dronabinol, the CRRB may consider either replacing medical cannabis with oral cannabinoids or dronabinol, or adding those to the list of compounds with evidence of effectiveness. Notably, while most of the evidence concerned dronabinol, there is very limited evidence for use of smoked cannabis for up to 3 weeks based on the general trials by Abrams 2003 and Haney 2005, which may have included some people with HIV-associated wasting.
Cannabis Research and Review Board meeting, which I totally did not have in the.
Sorry. The current formal statement about HIV wasting does not address specific efficacy outcomes. I present a few different options for the CRRB to consider if they wish, or if you wish to specify specific outcomes. Notably, the recommendations on this slide differ slightly from the full report because upon further review, I'm a bit conflicted. The first option is to maintain the evidence level of limited and add the outcomes of increased appetite or increased caloric intake and body weight to the statement. Another option is to add those specific outcomes and to consider changing the level of evidence rating for the outcome of caloric intake and or weight gain to insufficient. Overall, considering 5 low-quality trials, including 3 that targeted people with probable wasting and 2 others that may have only included some patients with wasting, the statistical significance of the results for appetite, hunger, and weight gain are mixed. The direction of the effect is for increased appetite in the 4 trials that measured it, whereas the direction of the effect was for increased weight in 3 of the 4 trials, and the 4th trial showed that patients treated with dronabinol lost weight on average. The CRRB may also consider updating the sections of the guidance document without formal recommendations, including some of the considerations on this slide. All right, so that's all for the presentation. As extra slides, I did include the National Academies ratings if it's helpful to refer to those, as well as a summary of more details about what the CBPs were that were studied that might be useful later when summarizing things. Please let me know if you have any questions.
Thanks, Lauren. Fantastic as always. So I guess as I was looking at this and looking through your stuff to preview, hey, Marinol was approved based on this evidence, right? And based on just a short-term appetite increase, but not even necessarily weight gain. And that was the basis for its FDA approval, huh?
That's my understanding. Of course, there were preliminary studies before that. and there's
Right,
a
right.
pivotal trial, but yes, that's why I think the wording for its approval doesn't mention weight gain.
Yeah, no, that's what I was just pulling up the package insert. It's all about appetite. It's anorexia associated with weight loss. So really it's just the loss of appetite and not necessarily weight gain or any outcomes related to nutrition and weight gain, but just the appetite itself, which was, I don't know, I guess I had assumed it was much stronger than it was. So that's helpful to refresh there. This seems like certainly one that, including the form of cannabis, would be that we'll definitely have to do. That this is, all around dronabinol studies from, the 90s or times like that, rather than, smoked or inhaled cannabis or things like that for all these things. Anyone have comments or questions for Lauren about the presentation here?
Well, I just have got to tell Lauren, man, this is a great presentation. It's fabulous. I'm glad she's with us. The one question I have, well, a couple of questions is, with oral, was there any specificity as to what type? Were these pills? Were these sublingual? What type of oral was in the studies?
Studies are a bit inconsistent in saying exactly what they did. I infer that it was oral, not sublingual in all the.
Okay.
If it was the Marinol or dronabinol studies, and those are just the capsules.
They're just a capsule, yeah. But I just wondered if they used
5
it.
or 2.5 up to 10 milligrams or something.
Okay. I mean, I look at this and I mean, I'm glad we're working on this, and I'll talk about it more with my presentation, but the question I have is, how do you relate, the pharmaceutical, whether it's a capsule, to what some patients may choose to substitute from the cannabis pharmacy? And how do we equate the difference? I mean, some patients won't do pharmaceuticals. So how do we inform them as to what they can use in the plant-based that would be an equivalent or close to it? As far as I know, we have no capsules or pills in this state. Do we have now?
We do. There's just not a big market for them, but they exist.
They do exist. So most people are using oils and tinctures and sublingual and gummies probably, or a gummy type. Yeah. Okay.
Yeah, we have. Go ahead.
Go ahead, Rich.
I was just going to say our monthly report shares information about the stats on what type of products are being purchased, and I could send you, Russ, those statistics so you could see how much of a percentage the capsules and tablets are of those that are purchased.
Okay. Great.
Well,
Thanks.
I just like to comment on what Russ was saying. I think part of our effort could be to point out these discrepancies in Laura's presentation on possible recommendations from the board. One of them, Lauren, I think you said maybe in that one statement we could say dronabinol rather than oral cannabinoids, or rather than what is there now. I think there was some statement that you stated. And I think that's exactly what we should. I think we should get more detailed. We're now to the point where we need to start pointing out the differences. And I think we should say these were dronabinol. These were studies based on dronabinol, not the products that are available today.
Yes.
So I think a lot of people will take issue with that. Dronabinol is produced, and isn't it synthetic anyway? I mean,
it's a synthetic THC. Yes.
It's just synthetic THC only, and a lot of people really believe in the entourage effect and what that might have. And we don't have a lot of proof yet, but that's the point, is we need to start identifying these distinctions and then promoting research that takes these distinctions into account. Yeah. And I think we need to start adding this level of detail to our statement so to point out the discrepancies. Yeah. And when we say there's only insufficient or limited evidence, well, that might be because it was dronabinol and not not the whole plant product or whatever. So.
Yeah.
So those recommendations, Lauren, I think we should take a closer look at those recommendations, maybe even homework again, and see
Yeah.
what we like about your recommendations.
Yeah.
They were many.
I concur with that. Yes.
I'll say at least the dronabinol is a consistent product instead of something that's vaped or inhaled and we don't know what someone's getting, or self-titrating of, we know they got this dose and we know it's just THC. Maybe that's product's not exactly available because there's going to be some amount of CBD or something, or maybe we've got enough that are 5 milligram THC quantities, but at least it's a little bit easier than the
You're
mishmash
exactly
of
right,
other
Mike.
things that we're going to hear about from Russ in just a moment about all the troubles with all these other ones.
That sword cuts both ways.
Yeah.
You know, you don't have the entourage effect with dronabinol, but yet you have a consistent product. So it's a dilemma.
Yeah. Well, I'm noticing, Lauren, as well, and for all of you, not a lot of these studies, they're looking at smoked cannabis as well, which we don't even permit in Utah. So we need something that speaks more to the vaping side of the administration rather than just smoking. I don't know how those two equate, but there is a difference between vaping and smoking.
Yeah.
I think this is an interesting topic because here are all of the complications associated with this disease process rather than, one specific symptom. And so we're left with pain or weight gain or whatever other pieces in here rather than treating a specific disease, which makes it kind of its own subset that then applies to other sections, like you said, of the chronic neuropathic pain in a separate document. And how do we reconcile all that here, which I guess we'll have to be careful to see how like Lauren pointed out, how do our statements differ in other documents, and are we consistent, or is there something very specific to HIV/AIDS with regards to some of these pain conditions that should have different language, or should they be equivalent or whatever else? Yeah. So thanks for drawing our attention to that.
Yeah, this is great. And the other thing I saw was when you're going through this, Lauren, is that I think there was one study in there that was more of a CBD-based product, and it was clearly not effective. And so again, this kind of gets into this THC, CBD versus other divide, and making sure that whatever guidance we put out will kind of steer people away from things that are not, that we do have evidence that they don't work, I think is important.
Well, I think that's a good point. We really should say whatever our recommendations are. This is, oral THC predominant. This is vaped, inhaled, smoked, CBD, etc. That I think that does need to go in, or at least be specified if it's a mishmash of different evidence. So letting people know what these forms are, because this keeps coming up for the board over and over of the evidence that we review and the available products don't always match up.
To address Dr. Kelly's comment, I just wanted to clarify, I'm not sure exactly which study you were thinking of, Dr. Kelly. I know I went through this all.
It was one of the first ones that was like when the Beal study was listed, it was one of those, and it was like CBDV or something.
Oh, yeah. The cannabidivarin, which is like a propyl analog, it's related to CBD.
Right.
That compound, yes, was not effective for pain. But I just wanted to clarify that there was one other study, Mabumba et al., that did study pure CBD orally up to 800 milligrams daily, but that study didn't measure efficacy outcomes. It was like a safety-focused study. And then all the studies that had smoked cannabis, they only included the percentage of THC in the compound, and so we don't know what else was in those cannabis strains they were using.
And just to highlight that we're talking about the types from the data that Rich mentioned and Sarah linked, cartridges and pens and flower are number 1 and 2 by a wide margin, with edibles in a solid third place if I'm looking at the chart right as far as what the typical sales are. But
Mhm.
you know, those other two, flour is about twice as much as edibles, and then cartridges and pens 4 times as much as far as dollar amount in sales.
Yeah.
But most of our patients are vaping cannabis. Then we need to have them know, is the evidence around vaping, or is it around edibles? Is it around whatever forms? I guess our next piece then for HIV/AIDS would be similar to what we just did for persistent debilitating muscle spasms, is updating the existing document and then bringing that to the board for review. I think that will be a bit easier since there's already an existing one and we're not creating something more or less from scratch like the persistent muscle spasms. But I guess we can plan that for the agenda for our next meeting, would be to make changes to that document and then bring it back to the board for our next meeting. All right, anything else before we move over to Russ's presentation? Okay, Russ, take it away on recommendations for researchers.
Great. Sarah, you put that, okay, good. So I wrote this really quickly about 10 days ago, and Sarah was graciously put up on the board for me. I didn't realize there was so much input until I looked at it this morning, and I am grateful because it was such a rough draft. And my thoughts were, do we have an introductory paragraph? Do we not only just list our desired things we want to see in the studies, but do we want to put in like explanations of why? I mean, is why even a question we want to talk about? So the list I made up was just based on the review of the notes and the minutes from January, and then some material that I had on hand that I had already kind of looked at over the years. I'm really appreciative, by the way, of all the inputs so far. The changes that I've seen this morning are just fantastic. And now, of course, more questions are coming up as we're talking about this HIV. So we can go through this. So the first thing was just a paragraph, just to kind of introduce, the reasoning behind having this list. I didn't know if we wanted to make it longer, more detailed, but so far it looks good. And then just, I just made up a list of like 6 or 8 items. People have combined a couple of them and eliminated some things. And this is exactly what I wanted. Delivery methods was the first thing that hit me, was vaping versus smoking. Most of the studies seem to focus on smoking. When we have vaping the raw plant versus vaping product. And as Mike just pointed out, a lot of the products we're selling are probably cartridges, which means they're a processed plant form. We need more studies about that particular product and how it's going to work for our patients with various conditions. Number 2 is specific types of cannabis. We don't even know. I mean, usually they refer to THC or CBD, but when it comes to the plant, we don't know whether what the profile is. And that was another question I had for this board. Traditionally, we look at sativa and indica and hybrid, but most researchers now want to look at the chemical profile. I don't know how you print that, how you blueprint a chemical profile for a given plant in a way that's cost-effective or meaningful for either providers or for patients. Any comment on that idea? I'm presuming, and I've not been to a cannabis pharmacy here, but I'm presuming we still use the term sativa and hybrid and indica, correct?
Yes, they do, though most
Right.
things are hybrid, and they might lean more toward indica or sativa.
Yeah.
From what I've read, it's not always reliable.
Yeah.
But there are some differences, and people get passionate about one or the other, and indica seems to be more medicinal to me. But if you're using the whole plant product, then you should specify. If we're doing research to add as much consistency as possible.
Yeah. Well, that and then that, you know, I mean, I actually saw a review or a researcher in Israel who they have like 500 different plant types, and they actually create a chemical profile for each one. We're not doing that here, and I don't think we could really effectively do that here, but we need to at least specify the basic temp, you know, plant profile. That would be helpful.
Someone gave me a poster for Christmas that has the periodic table of cannabis. It has a number for each one.
Yeah. I mean, I don't know if you even know, but when I first started teaching, there were over 1,600 different variations of cannabis over the years through hybridization. It's probably over 2,000 or 3,000 now. I don't know how you even can track such things, but and even from grow to grow, the chemical profile can change a bit. But I would like to at least have some understanding whether it's sativa dominant, indica dominant, whether it's a more balanced hybrid, that at least kind of gives us a little bit of a generic piece of information that might be relevant for a patient going to a pharmacy.
I agree. And maybe the only thing you add to that statement is just that. Is it, what kind of hybrid is it?
Right.
Or if there's a certificate of analysis available, you can.
Yeah. Assuming that analysis is completed, you know, a complete analysis, and with all the terpenoids and all the other products that are found in the plant. Yeah, that was the reason for that one. And the researchers don't even tell us. We don't often know what the source is.
Does anyone know? I mean, I'm still kind of new to a lot of these things, but is there a group nationally or someone working on like some type of nomenclature to describe? I mean, like there's all these different properties of cannabis, right? Like the kind of drug that it is, the kind of properties of the plant it comes from, the type of formulation. It seems like there's just a need to like really put this into a nomenclature so we know exactly what we're talking about at any given time. But it seems like that's missing.
Absolutely.
That could be a statement in there too, is we need people to define, you know, which things are important and what needs to be there, and then report at least what you're using. And then, so after the fact, as we find out more, we can look back at the other studies. So.
You could start with the basic one that Utah did. They labeled it chemotype 1, 2, and 3, and
yeah,
you know, THC predominant, balanced, CBD predominant.
Yeah,
that's at least a start of chemotype.
Yeah, I don't know if there's a standardization. I know that now there are some groups. There's a group out of, I think, Colorado that's actually looking at the terpene profiles of the plants and how those influence a given experience. But there's not a lot of research on terpenes. I know that Dr. Russo did one on limonene, but it was for him, it was a proof of concept study. You know, if you look, and I can send you it's published at the NCBI, but basically it talks about how it mitigates, you know, anxiety effects of THC. But he even admits it wasn't designed for that. It was a proof of concept, you know, and so that's the kind of thing we're running into. But we need to be asking about these things so that researchers have this in mind, because I know that it's easy to study a single molecule like THC or CBD or whatever, but that's not what patients are using. Unless they're getting a pharmaceutical, when it comes to the plant world, they're using a combination of products, and we need to understand how this is working in individuals so we can make some recommendations. Everything I'm recommending to my students is based on clinical feedback and some, you know, preclinical studies, but I don't really have any good clinical studies I can refer to.
Hey, Russ, can I go back to number 1?
Yeah, go ahead.
I love number 1, but I think we could add to it. So the delivery method used is important. But number 2, I'd say make it a single delivery. So pick one. Is it going to be vape? Is it going to be edible? So I think we need to, if I were suggesting research, pick one delivery method and we would promote vaping over smoking or edible,
Right.
you know, gummy or tincture. So that, what would we want? I mean, that's the whole point of this document is, what do we want? Well, I would want to see a study with just vaping, or a study with just edible gummies, or a study with just tinctures.
I
You
agree.
know?
Yeah.
So I think we should say that. I think we should go ahead and say it.
Be specific about that then.
Yeah.
Okay. Because most of the people I've talked to they want to use oral. Now for them, it's either gummies or it's a tincture. There are people who love the vaping, and from what was just said, vaping is apparently one of the highest selling products in the state. So we want to see a study with vaping. And we want to see a study with maybe, maybe gummies. I don't know. I'm not a big fan of gummies, but
Well, maybe you could do tinctures and gummies together, but the point is, we want one type of delivery method studied
okay, at a time.
at a time. Yeah.
Okay, I agree. Yes.
Well, I would say, within the same study sample, you could certainly have two arms and like
Yeah,
you can
exactly.
compare multiple at the same time, but in the same individual, yeah, you don't want to confound it by taking tincture today and vaping tomorrow, and
Yeah.
or both at the same day.
Okay.
So I don't know
Yes.
how to word that, but I think that's that's point number one, is use a consistent product,
Yeah.
consistent delivery method. And I'd love to discourage studies that look at smoking. I mean, I want to discourage smoking everywhere I can.
Yeah. I'm going to concur with you on that one too.
I think you could just say, for the point, that there's only one delivery method per study arm.
Okay.
Yeah.
I like that. Yeah.
In the comments, I just shared a link to a report that the FDA did working with the USP convention, trying to standardize how things are reported with medical cannabis. And the table kind of with their overall thoughts.
And in some ways, number 3 kind of is a subset of number 1, in that I want to see products that are studied that patients are actually using. And I'm not sure how that would look, but pick something that is like, we can look at what's being sold in Utah, if this is going to be done at the U of U, and pick one of the most known and well-used products that's available to patients, and let's see how it works in different ways, depending upon whether it's oral or vaped, or whether they're using it. Most people here are using it for pain. Even if they have another condition, the comorbidity of pain is always involved, whether it's neuropathic or inflammatory. And I think I mentioned that before, and I think whoever was here from the ag department said that they have products that have been rejected but could be used for studies that are available to patients.
So that's actually something that came out of the Medical Cannabis Policy Advisory Board, working with the Department of Agriculture here.
Right.
We've worked on Brandon Forsyth in particular, and I've worked on the regulation and getting it so that the products that are collected to be used for quality control, instead of Department of Ag incinerating them and disposing of them, those would be able to be applied for license holder to license holder and transferred for research purposes through Brandon. So just like you would order a Schedule I compound through a commercial vendor, that way you can maintain diversion controls and whatnot and record keeping using a Form 222.
Okay, good.
But with the nice thing about that is that would come with the certificate analysis and things like that.
Right.
So Misty, how would you modify number 3 then? Did we need to say anything more about that? Because essentially we're trying to make instructions maybe for the U of U or a model for other states of what we want to see.
Yeah, I think I think a similar document to this is actually under construction at the center.
Oh, cool.
I don't know if it's been as like formally prepared like this, but I think that I don't think the change in the regulation has actually been incorporated into it yet. So I actually haven't transferred anything because we were until last week waiting to hear about seed grants and whatnot, which that all came out last week. So yeah, I think you could just say preference should be given to using cannabis products the same as or similar to those commercially available, not commercially available through the medical cannabis program.
Right. The drawback, the barrier to that is that if you receive federal funding, I don't think you'd be
Correct.
able to use those products, but if you're able to get funding from other sources.
Correct. That is absolutely correct. Yeah. Yes.
I guess that kind of goes to who's our audience for this. So someone who's coming up with a trial in another state is probably not going to care what the Utah board says about how they should do their study. Obviously, we have the Center for Medical Cannabis here at the university and things there. Or is this just trying to continue to promote that message to everyone out there in the greater world of medical cannabis research?
I imagine other state cannabis centers would be interested in this. So if I were in Florida and I'm trying to figure out, well, do we want to set an agenda for what people in our state are looking at? This could be a springboard of some sort, maybe.
Yeah.
I think other states might be interested. I think we should at least try to influence that. I don't know if it's through the cannabis regulators, convention that Rich went to, or if we collaborate with other states, like Florida. What if Idaho comes and finally asks, hey, we're finally going to do this. What should we do? That's more the state regulator thing, but
it could be a template. It could be a template,
a template for the University of Utah. If they collaborate with other states or other universities in research, then say, well, these are our guidelines for how to pick a study.
Well, and what this closely resembles is actually the recommendations that were given out through the Center for Medical Cannabis when they announced their first round of grants for seed grants. This is very similar to what they had in their introduction of like priority areas. So, I think this could be, this is more detailed. They were basing that off of, what it's clinically most used for, but this goes into a little bit more detail, and is more general, about what we expect in reporting, et cetera. So.
Yeah. And so after this is finalized, what we can do is we can share it with the University of Utah Center for Medical Cannabis Research, obviously, and then they could decide how to incorporate it into their own operations. And as we discussed, that they're already, incorporating these principles in information that they disseminate. And then I am a member of I'm co-chair of the Medical Cannabis Research and Medical Use Committee at CRRB, and I'll share it with that group. I think it'd be very helpful for them. These are these are professionals that work in regulating bodies across the US that for one reason or another have a duty that connects with research. And so I can share this with them, and I think they would find it helpful as well.
If this is also, if you scroll down and are talking about actual clinical trials, with patients, I think it's really important to also get a better understanding of other medications the patients are currently taking, because I think the drug-drug interactions really need to be addressed better in the clinical trials and even case studies that you see reported.
Are you saying like also like just concurrent therapy for the same condition,
Yes.
or just whatever other drug-drug interactions could be occurring as well
Well,
besides
even
concurrent
the
treatment?
same condition would be a good start, because usually that is not well addressed.
I think that's certainly good. So safety, that can include adverse reactions and drug-drug interactions in number 6. And maybe I don't know if that's a separate point of, but concurrent medications, especially those used for the treating the same condition.
Yeah.
I have another comment on number 3 that's just a little bit on the other side of what everyone's been saying about, products that are available. The research should really drive which products are available, not the other way around, right? It shouldn't be the manufacturers and the patient demand that influences what the studies should be. We should be finding the best evidence, and then that should influence which products are available. I recognize being pragmatic, and we want to know if what people are usually doing is good, but we also want to compare that to,
You
is
mean you
there
want to be
other
science driven versus market driven? Really?
Yeah, like what is the preclinical evidence that that Misty is doing, that is saying like here is what's good versus what's actually available. So there has to be some balance of
I wish that was the case, but I don't know how
pragmatic
you.
trials
Yeah.
versus also trying to figure out going to the chemotypes and things like that, and the dosage forms, which I guess get at all those same points of we need to know what this is, and we would like to see we'd like to have it all, right? We want to have our cake and eat it too, of what's available
I
versus
totally
what is
agree
best.
with you, but I feel like that's paddling up the waterfall,
Yeah.
Yeah.
I think what it's going to be from my point of view is if we look at what's already available and start showing efficacy or not, it will start to inform a change in the industry.
Right.
Yeah, 'cause we're certainly not unique in Utah where everyone's vaping, right? That's not unique to Utah.
Let's go to number 4 real quick. I think number 4 is kind of a duplicate of number 1 now. So that could probably be removed.
Yeah.
And then the new number 4, frequency and absorption. I would like to see more on absorption rates. There's some preliminary studies. I can pass them along if you want to look at them, but we don't really know. And it is variable from individual to individual, but we need some baseline at which to operate, and that we can inform patients how to take, a given product, whether it should be sublingual and then swallowed, or the vaping and how long to vape for. We need to understand that better.
You're basically asking for phase 1 pharmacokinetic studies, huh, Russ? Before you go with the efficacy studies, we have to know the absorption, the administration, and the dosing, and
it's
all that.
all by anecdotal at this point, and we don't really understand it well enough.
The only other suggestion that I would have is a statement requesting they consider sex as a biological variable in studies, because a lot of these studies, as we just heard talking to Lauren, were biased towards males.
Yeah.
And there's a lot of evidence to show that there are sex differences.
Good point, Misty. Yes, I agree. Let's add that in there.
I also just wanted to mention, I'm not sure if this is included by just saying delivery methods, but in interest of being super specific about what we might want. Personally, what I would want, if someone is using like a vaping method, they should specify like the depth of inhalation, like how long they inhaled for, how long they
And how
held it
deeply they
for.
inhaled it.
Yeah. And also they need to specify specifically the delivery device that they used.
And this
Well,
is
if we're
where,
going to be specific, let's be specific here.
yeah. This is where it gets difficult making the jump from the preclinical to the clinical because the vaporizing devices used preclinically with rats and mice. You know, the best we can do is give PK/PD afterwards and talk about brain and blood levels.
The other comment, I saw Dr. Kelly had a comment hinting at this. Is this document intended for like clinical research, like interventional, experimental studies versus like observational studies? Just because you might expect different levels of data or available reporting about like methods used for inhalation for an observational study versus a clinical trial.
And Lauren, just to add to that, I mean, I brought that up because just like Mike said, this is sort of market-driven research where the product gets out there, people start using it, and we're trying to figure out what happens. And so you'll have lots of observational data before you ever have experimental data, which is kind of the reverse of how we do most anything else.
Mhm.
Everything about cannabis has been reversed.
Well,
So it seems that this is focused on clinical then, or both.
I would
say both.
I would say both.
Yeah.
Yeah. Definitely. And the other thing is we need to convince research to not just look at individual molecules, but also look at product as a whole. And that means we need, like you say, the chemical profile, the analysis. So we know, this is what was done in Israel. This researcher, and I can't remember which university it was, they had a woman who had severe chronic pain, and the plant she was using or the product she was using was no longer available. So they took whatever was left of her old product, they did an analysis on it and looked in their own database to see if they had a plant with a similar profile, because she tried, I guess, a dozen or more other different products and none of them were working for her. But this one product did. And when they were able to replicate the profile, then she had relief of pain. So this is kind of what I'm asking here is how can we affect that? How can we create some influence here in the States of doing the same kind of thing? Because I've seen the same experience with clients who come or students who come to me and say, hey, this product worked, but I can't get it anymore. And I've tried to replicate it and the new ones don't work the same. Or I need to have a massive dose and then I'm too high and I don't like that. So we need to somehow articulate this in a way that we see research actually doing the same kind of thing, looking at what's working or what isn't, and then telling us how to replicate that in the market. Lawrence says, mentioning the temperature, yeah, that's important.
I'll just make one more comment about the audience that Mike brought up. Obviously this is trying to be feedback to research organizations about what we want, and please don't keep doing crappy research, but don't underestimate the impact it has on clinicians. I mean, I'm a clinician, but I took epidemiology in med school for a reason. You can't just read studies without knowing what you're looking for. And being able to recognize a good quality study versus not, and every clinician needs to know that. Otherwise, people will believe anything that's on the Tonight Show. So,
yeah. What I'd like to do is continue working on this, do input for till the next meeting, and then maybe we can finalize it and have something that's more ready by October.
And
Yeah, I
put
can-
this on everyone's homework list too.
Yeah, I was gonna say I can send a follow-up email with items to
Yeah,
do
I think
between.
Sarah, we need our task list after
Yep.
today. This is all great though. I do want to put in a plug for the two that I added at the end. I don't know if they're 6 and 7 or whatever they are now.
Yes.
You know, this just came up with FDA reviewing the application for MDMA, right? Where they said like, you know what, this is like no one was really blinded to what happened, and it's a really difficult problem studying psychoactive drugs. Is patients know what they got, and they come to these studies with a lot of expectation and past experience. And how do you sort that out? And how do you take your average person who never thought about using cannabis versus someone who has used cannabis quite a bit and then gets involved in one of these trials? And what does that mean about the population that you're studying? And I don't
I
know how
agree,
clear
Mike.
that is in so many of these.
I wholeheartedly agree. I mean, I consider my patients that use cannabis in two groups, those that already used and those are the ones that I started. And I love those because I know they were cannabis naive and I
Yeah.
coached them from the beginning. And I really love that feedback because I know it's unbiased. So I think that's a great, I don't know how to improve that statement, but
That's
I
number
like, in fact,
7. Yeah.
in fact, the Sublime study, the University of Utah is doing the Sublime study, and you had to have a card within 6 months to be part of that study where they are assessing your response.
Right.
Well, we're probably getting close to the end of our agenda time, and it sounds like we've got a bit of homework to do on that. Any other pieces before we do our last few things?
No. If I have to cut out, excuse me, I have to go to the airport soon. So
Well, thanks for all your work on that, Russ. Thanks everyone for all your comments. I think it's going to be a fantastic resource and hopefully can set an example for, you know, the state, for other programs, and just kind of amplify this need for good quality research. Sarah.
All right, I just have a couple of quick updates. The first is that, as you guys may know, we have the EVS system, a new system that's going to be launched, and we have created a web page hub on our website. So if you click on EVS, it's also on our homepage, and this has everything you need to know on here, and we'll have updates and trainings on here. So if you have any questions about the EVS or have any patients or colleagues who do, this is a great place to go.
And just really quick on that, Sarah, we sent out an email last Friday to all QMPs, QMP proxies, pharmacists that work at the medical cannabis pharmacies and pharmacy agents, that gave them a heads up about the launch on August 5th. And then also that gave them a heads up about webinars that are beginning on July 22nd. Those are happening between July 22nd and August 1st. And so those webinars will just be critical opportunities for people that use the EVS every day to be able to get trained on what it will look like when it launches on August 5th. So yeah, that's all.
Yeah, thank you for that. And then we have our 2 newsletters going out on July 15th. And I might have mentioned this in the last meeting, but we're dividing them up for patients and patients and providers. So the newsletter will be kind of more geared towards the audience. And that'll be going out in July on the 15th. And then Snowbird CME, we're going to have a booth there at the conference. And that'll be at the end of this month. So if any of you are joining that conference, we'd love to see you stop by our booth. And I believe that's all the updates that I have, unless you have any additional ones, Rich.
Just one additional one. There's a new administrative rule that we'll be presenting at the Medical Cannabis Policy Advisory Board meeting next week, next Tuesday. And that's targeted marketing standards for qualified medical providers and affiliated medical offices, and just set some very basic standards for how they advertise. And Sarah, I can have you email out to board members in case they're interested what that draft looks like. At this point, the rule has not been filed. It's just the law requires that we get input from the Medical Cannabis Policy Advisory Board. And so about rules that we're drafting. And so we've done some work internally, drafted, and now we're just sharing it with that policy board. And then also next week, I think there's going at the MCPAB meeting, there's going to be a continued discussion about use of strain names in advertising. And as you all know, the strain name shows up on a product label in very fine print, not primary location on a container, very fine print. But that strain name is awesome, recreational in nature or appealing to children. Right. You've got some strain names that are just shout outs to very common candy like Skittles or Runts or whatever. So Utah Department of Ag and Food has the ability to restrict the use of strain names. And so that discussion is going to continue next week. Also there was some talk about maybe adjusting how it's advertised online. Because while the strain name is not the primary focus of a container, it's in fine print, it is often the primary focus of how something is presented online to people over 21 that get access to the to inventory and order online. Often you'll see that's one of the common ways that people will see the strain name outside of the product label is when it's advertised online. So that is an ongoing discussion. Also, the DEA's proposed rule to reschedule marijuana from Schedule 1 to Schedule 3, that the deadline for public comment is July 22nd. So that's coming up soon. And I know there's some entities that have requested a public hearing for that, and we'll see what happens, whether there are some public hearings that get scheduled for that. But yeah, that's coming up. And also, we just recently, just this week, an epidemiologist from the Office of Health Equity is starting to spend a quarter of their time supporting our office, and they'll be helping our office with some, in the future, some patient surveys, potentially collecting additional demographic data from patients, and also helping us as we just work on various projects that relate to epidemiology. And in the future, they'll be joining these meetings. So we're excited to have at least a quarter of their time during the next year. That's all.
All right. Thanks for updates there, Rich. We're getting close to the end of time, and make sure we can have at least a moment for, I guess, any other board comment before we move to public comment. Okay, I guess if we have any public comments, I'd ask for anyone to just hit the raise hand button for us, and then we'll call on you, and just a reminder to let us know who you are. I'm not seeing any hands raised. Anyone there that had anything to comment to us here from the public? All right. Well, thanks for listening. Anyone who's here who's not part of the board or DHHS, thanks for hanging out with us and listening. Anyone have any other last points before we get a motion to adjourn? we'll
You
plan
did
for
a
our
great job
next-
today, Mike. You did a
Hey,
great job
thank-
today, Mike.
Thank you, Rich. Thank you. Thanks,
All right.
all you guys. You guys all make all this happen. To everybody, to Rich, to Sarah, to all the board members and everyone else. So thank you very much. Our next meeting is planned for, did we set the date is October
It's in the
11th?
calendar. Yeah, let me double check. October 8th.
October 8th.
Yep.
All right. So make sure you're signed up to get those notifications. We got that on the calendar. We got lots of homework assignments before October, and Sarah will remind us, and hopefully we can work on that with a deadline sooner than October 7th to finish some of those things throughout the summer. And with that, I guess I'd take a motion to adjourn the meeting.
I motion to adjourn.
Second.
All right. Everyone in favor of adjourning the meeting? All right, motion accepted, and our meeting is officially adjourned. Thank you, everyone, for all your great comments today.
Thank you.
Thanks.
Thank
Thanks.
you.
Take care, everybody.
Bye, guys.